Okay, so welcome everybody. It's great that you could join us this evening for our student webinar on frailty in older people. Big hello from me. I am Izzy Hall, one of the student coordinators here at the CSP. And we've got Leesha with us tonight. Leesha, do you want to say hello?
Hi, I'm Leesha. I am one of the CSP Student Reference Group Events Officers, and I'm also Student Officer for Agile. So I'll be talking to you a bit about Agile student membership towards the end of tonight's webinar.
Thank you, Leesha. And Justine?
Hi, I'm Justine, a senior physiotherapist, and I will be talking to you about frailty in a minute.
Thanks, Justine. So, yeah, we really want you to get involved in the webinar tonight. We want to take any questions you have, really want it to be interactive. So there is a Q&A function. Please do pop your questions in there. We will keep an eye on it as we're talking. And then we've made sure that there is a good opportunity at the end of the session to take any questions directly. So feel free to save them until the end if you prefer. I'm just going to run a quick poll to see how you're all doing today. And also to find out what year you are in, what year of your studies you're in. So I am launching our welcome poll now. Hopefully you can all see that. If you could just please vote, that would be fantastic. Oh, you're so speedy. Thank you very much, everyone. Most people are feeling good. I thought there'd be quite a lot of feeling exhausted. I know it's such a busy time for you right now. So yeah, really appreciate you joining us tonight. This is going to be a really good session. Okay, lovely. 5 more seconds and then I'll end the poll. Brilliant. And I shall share that with you so you can all see. So we've got most people feeling good, and then exhausted, and then on top of the world, which is amazing. So those 6 people who are on top of the world, wow, you can spread those good vibes. And what year of your studies are you in? Predominantly 2nd year, and then 3rd year, 1st year, and finally 4th year. Perfect. Right, we are going to record the session, as I said, so I will make sure this is sent to everybody at the beginning of next week. So I would now like to pass over to Justine. So bear with us a second while she uploads her slides. Okay.
Thank you very much. Let's share that. Good evening, everyone. Like I said, my name is Justine, and I am a senior physiotherapist. I work with the Hertfordshire Community NHS Trust, and currently I'm working as the advanced care home practitioner. So I support care homes to provide quality healthcare for their residents. Okay, so tonight we are talking about frailty in older people, and I have added the question, what can the physiotherapist do? So our learning outcomes are stated here for us to understand what frailty is, the importance of frailty, how to identify it, frailty syndromes, how to recognize them, the 5 M's of geriatrics, the stable and unwell person versus the deteriorating person, and the role of the physiotherapist. So what is frailty? I wanted you to type for me in the chat what you think the answer is to this question. So if you can please go ahead and type in the chat. 1 second. So I can't see the chat. I don't know. Izzy, can you tell me some answers?
Yep. D, B, D, C, B. There's lots of different responses.
Okay, brilliant. So thank you very much. The answer is D. You are very right. So frailty is a state of increased vulnerability to poor resolution of homeostasis after a stressor event. That's what the BGS says. So what that means is someone gets a small problem and then it really makes them dip, and then it's difficult for them to come back to their usual self. So it is, they lose their inbuilt reserve, and it happens with aging, but it is not, it's not an inevitable thing that happens. So as people age, they are, they lose their reserve. But then the question is frailty an inevitable consequence of aging? And if it is, would you say that our queen is frail? Yeah, so because she's 95 years of age. So how do we tell what frailty is? So there are frailty syndromes, and there are 5 of them, and I've listed them here. So one is falls, and you'll often hear things like, oh, the legs gave way, or she was found lying on the floor. Then there's immobility. So there's sudden change in mobility. They'll say, oh, I've gone off my legs, or I couldn't stand up from the toilet. Then the third one is delirium. So that's acute confusion, muddledness. It's a sudden worsening in confusion. So for some people, they already have dementia. So, but then in this case, the confusion is increased. And then the fourth one is incontinence. So suddenly they are incontinent, or of urine or feces. Then the fifth one is susceptibility to side effects of medication. So yeah, we will be looking a bit more at medication in a bit. So this takes us into the 5 M's of geriatrics. And so these 5 M's, it's mind, mobility, medications, multi-complexity, and what matters most. I like the way they are listed because it's like they keep increasing in the number of characters, and it helps you to remember them. Yeah, so that's what the 5 M's are, and they are related to the frailty syndromes because, but in this case, they are the bigger thing. So if we got to talk about the mind, what happens to the mind as aging progresses? There's slight cognitive changes that happen. That one is expected. And as you can see in this graph, there is the preclinical, and then there's where someone has mild cognitive impairment. And then as it progresses, in some cases it progresses and goes right down to dementia, where it's classified as mild, moderate, or severe dementia. So with the mind, there are 3 Ds, 3 main Ds. So that's, we've just talked about dementia, and then there's delirium and depression. So when it comes to delirium, there are many causes for it. So things like dehydration, things like medication, maybe someone is not taking their medication, maybe they're in too much pain, maybe they are not sleeping well. So all these things can cause delirium. So how do we prevent it? It is listed on this slide. So sensory enhancement, we want to be talking to this person. Yeah, we want to be talking to them and reorienting them, letting them know where they are. So I want us to answer this question quickly. What are the consequences of someone living with frailty, having delirium? So if you put in the chat for us the answer, and then we'll move on to the next thing. Izzy, are you seeing any answers?
Just starting to come through. B, all of them, all of the above, all.
Okay.
Yeah, quite a few people saying all.
All, okay, yeah, they are right, it's all of them. So the question then is, what can the physiotherapist do? So if someone has delirium, like I said, we want to encourage, we want to communicate with them. And I'm going to go back to the previous slide. So sensory enhancement. So communicate, talk to them, and let them see where they are, what's going on, explain things. If you're going to touch them, you need to tell them, I'm going to touch you here, rather than just touching, and then they get scared. Then cognitive stimulation, orientation, fluid and nutrition. So as a physiotherapist, you encourage them to drink some more, and you encourage them to eat. I've had times when I've gone to see a patient and the relative says they are not eating well, and I sit with them and I make sure they eat something, or I leave after. I'll tell them, let's finish this glass of water, and I make sure they've drank it all. So yeah, so then simple communication. So break things down, simple words, and rather than give long sentences, just simple words, short, sharp instructions. Then mobility enhancement, we want to get them moving as soon as possible. And then we need to promote sleep. And if they are not sleeping, then we can liaise with the GP to check if there's anything they can do to help them to sleep better. Then medication review, we can refer for that. And then pain control, we can also refer to the GP. So what I've put here is what can the physio do? So we will think about modification of the home to support independence. So in case that maybe if you want to give like equipment and there's not enough space for them to maneuver, then you would encourage for some modifications to be done to the environment, so that the frame or whatever it is you want to fit. So then we'll provide equipment or assistive devices. Now, some of the equipment we can provide as physiotherapists, and some of the equipment we need to liaise with our OT colleagues. Then there is liaising with social services. So if someone is not coping in their environment and we want them to remain in their environment, then we can refer to social services. They might be able to get some carers in, and then they'll be able to be supported to be independent, to remain in their own environment. And then liaising with the GP, like I've said, if there was an infection, if there are medications that are implicated, like if it's pain medications and you would like that to be reviewed, then you liaise with the GP. And then we aim to support the patient to remain in their homes safely. And above all, we also liaise with the family, because the family members play a key role among the older people if they are to remain in their environments. So the next M is mobility. So what is mobility? It's the ability to move freely. So some of the factors that affect mobility, I've listed them here: muscle strength, balance, sensation, pain, energy levels, diet. Sometimes these older people, they lose appetite and they're not eating very well. So if they don't have energy, then they are likely to be frail. Then gait is affected by different things, the comorbidities like Parkinson's disease and other things. And then energy levels I'd mentioned, motivation, they might be depressed, environment, vision, cognition, medication and equipment, and many other things. So recently the BGS and there is one of the NHS trusts, they launched this campaign, sit up, get dressed and keep moving. So it is very important for older people to get moving as soon as possible. I've worked in the community for most of my physiotherapy career, and I find many patients who will tell me, I was in the hospital for 2 weeks and I only saw a physio once, so I only got out of bed once. So if they stay in bed, they lose their their muscle strength very quickly, they deteriorate very, very quickly. So, and then they are also at risk of pressure sores and many other things. So we want to get them moving as soon as possible. And this is something I'm passionate about. So if you're working as an inpatient therapist, please, please, please get patients to move as soon as possible, because sometimes we worry about their blood pressure, sometimes we worry about their sugar levels, but these are things most of the times they don't get resolved quickly, and they will get discharged home with those very conditions. And then we who are in the community have to go in and still support them to become mobile. So it so if the toilet is low, then we put a toilet, a raised toilet seat, or we put a frame around it so they can be able to use the toilet. If they need a walking frame, then we give them a walking frame. If we need to put chair raisers, we put them on so they can be able to stand. If we need to use equipment like the rotor stand and return, we try those just so we can get them going. And then we would encourage them to eat independently and wash and dress as much as they can. So in the
Justine, your video just seems to be having a few connection problems there. I wonder if it might be worth turning off your video, because sometimes that does affect the sound. It can mean for a better connection if you have your video off. Justine, if you can hear me, would you mind switching your video off, and hopefully your sound will come back.
Hello,
there you
can
are,
you hear
you're
me?
back. Yeah, you froze. Do you want to share your screen again, because the slides
Okay.
are now?
Sure, I will share my screen.
As I said, it might be worth just switching.
So I was talking about this.
Off.
Sorry?
Sorry, I was just saying, it might be worth switching your video off, because sometimes it does make it better connection.
We'll try that.
Brilliant,
Okay.
give that a go.
So
thank you.
Okay, hopefully it will work this time. Thank you very much. Sorry about that, everyone. Yeah, so the sit up, get dressed, keep moving campaign. I would like us to take that going forward, whether it's inpatient or in the community. And there was, in the past, there was also the NPJ paralysis. So patients are encouraged to get dressed and not just stay in their pajamas. So how do we identify frailty? So there are several tools. I have listed them here. So they're in the primary care setting: gait speed, timed up and go test, grip strength, Prisma 7 questionnaire, Edmonton Frail Scale, but we mostly use the clinical frailty scale, which is also called the Rockwood scale. So at the moment, there's a push for it to be used every time we assess patients, because obviously it helps all the healthcare professionals involved to know what to do. So this is what it looks like. So it divides the frailty scale, which is obviously on a continuum. So you can be very fit, like yourself, if you, you must be very fit. And then there are some who are just well, or managing well, or vulnerable. So moderately frail, most of the patients I've seen in the community, they start from moderately frail, So here they need help with all outside activities. So they are technically housebound, and so we have to work with them within their home to support them to be safe and independent in their own home. And then obviously they severely frail, then not severely, very severely frail, and then the terminally ill who are about to die like within the next 6 months. So depending on what the frailty score is, it will affect your intervention. So if it is 4 or less, then you can signpost to the community health and wellness services. And this will be mainly for people, for therapists who are inpatient, or patients or therapists who are working with the like frailty clinics or outpatient physio. Because for us in the community, we tend to find that most of the people who get referred to us are around frailty score 6. So then if it is frailty score 5 and above, they need to have a comprehensive geriatric assessment. So if they're in the acute setting, that should be included in the discharge summary so that the GPs and the other professionals in the community can follow it up. So this is the comprehensive geriatric assessment. It is a multidimensional, interdisciplinary diagnostic process to determine the medical, psychological, and functional capabilities of a frail older person in order to develop a coordinated and integrated plan for treatment and long-term follow-up. And it includes many things, and it involves a multidisciplinary team. Not one single professional can carry it out. So like in our trust, we have what we call the core assessment, and it covers so many aspects. So an example is if I showed up at a patient's door, maybe they had a fall, I will, and they were referred by the GP. So I will be asking them how the fall happened, if they're eating well, if they are drinking well, if their skin is okay, if they can feel in their feet, if they are happy or sad or depressed, can they get on and off the bed okay? So it is a very, very holistic assessment. So yeah, so then the third M is the medicines. So 30% of people age 75 and above take more than 6 medicines. And this is known as polypharmacy. So polypharmacy and aging are not very good friends. And why do patients end up being in this situation of polypharmacy? It's because of the multimorbidity. So as people age, the different systems start declining, and then they end up with different diseases, and all those different diseases need different medications. So then sometimes you find these drugs, they produce adverse drug reactions, and also there's the issue of adherence. So sometimes if a patient does not take some of the medicine they are meant to take, that can also cause adverse drug reactions. And in the end, you end up with issues of mobility, falls, delirium, and incontinence. So it is very important that patients take their medication like they should. So what can the physio do about it? So when we go in to see a patient, we record the medicine that they are taking. So in the past medical history section, we write down all the drugs they are taking, and then we would ask them, so what is this? Like, I'll show them the drug, and then I'll ask them what it is and why are they taking it. So it's important that we establish that they know why they are taking what they are taking. Because sometimes you find some of them have been on certain medication for a very, very long time. And sometimes you find they actually don't need to still be on that medication. So it's important to find out if they know what it is for. And if it's not necessary, then we can liaise with the right people to deal with it. So then we try to find out, are they managing their medications as prescribed? Sometimes they'll tell you, oh, I forgot, or I forget. And you need to find out, can they manage to open? So if you've done your assessment, if you're looking at them, you can see they have weakness in their hands, or their dexterity is poor. They are not going to be able to pop the medicine, the pills out of the blister packs. Then you advise, you liaise with the GP. So I would get back to the office and ring the GP and say, could this person have a dosette box? Or you can liaise with the pharmacist if you know how to get in touch with them. So with the dosette box, then all the pills are placed in the same boxes, and then they are marked for AM or PM. So rather than them having to open different blister packs, then all the drugs are in one little box, and it's easier for the patients to take. So then another thing to establish is, are they able to swallow? If they have swallowing difficulties, then maybe you check, are they taking tablets, and are tablets the best thing? Or maybe they might benefit from liquid medication. So some of the drugs can be prescribed in liquid form. So that's something also we can establish. And then we also need to check if the patient has had a recent medication review. So the recommendation is that at least once a year, every patient should have their medication reviewed. And if whoever is reviewing finds out that some of it is no longer required, then it can be stopped. So I put here, poor adherence can lead to adverse drug reaction. So we need to make sure that these patients can be supported to adhere to their medications. And if it turned out that the dosette box is not going to solve that problem, so I hope everyone knows what a dosette box is. So it's a box that has little compartments where the pills, so if someone is on like six medications, so you put all the 6 for the morning in one little compartment, all the 6 for the afternoon in another little compartment, and it's nicely labeled and it's easier for the patient. So if they were not able to manage independently, even with a dosette box, then we would liaise with social services to put in a care package. Or we can liaise with the family members. So initially we start with the family members. Some of the family members are willing to come in and support, and others live far, or they have commitments and they are unable to support this patient. So then a care package needs to be installed to support this. So definitely medicine, sometimes physiotherapists, we think that's not as much of our business as mobility, but actually it is. So then the 4th M is multi-complexity. So there's what is called a biopsychosocial model of health. So as you can see, it covers everything. Okay, not everything, but many things. So health is not just the physical body. There are other aspects like the psychological and the social. And it involves things like family circumstances. If, for example, you've gone to see this patient and maybe their wife recently passed away, the way they will respond to your to your interventions, to what you're suggesting, will be different might be different from someone else who is not grieving. So we need to think about the whole picture. And then obviously the biological, physical health, disability, drug effects. So if someone is taking certain drugs, certain drugs make some people drowsy. So you want to think about all those factors. And if the drugs were making someone drowsy, then it's important to talk to the GP, and then they can see if they can prescribe a different drug that does not make them as drowsy. Then things like self-esteem and coping skills, we end up having to encourage and explain why we are suggesting the interventions that we're suggesting. And obviously family relationships, they can affect positively or negatively. So sometimes you find a family member who is very interested in their relatives' health and well-being, and they are keen, and they come in and they support. You leave an exercise program and they come in and supervise and encourage, and that makes a whole big difference. It's a complex thing. It's not just one aspect. So then there's the issue of the deteriorating patient versus the stable patient. So with there are age-related changes that happen with aging, and these may affect vital signs. So you find that things like the cardiovascular function, it changes, the kidney function, and you'll find some of these things affect the vital signs. So if you take the vital signs and they seem abnormal, you have to look at other things, at other aspects. So someone might have blood pressure that seems low, but then they are fine. They are not dizzy. They are managing to do their day-to-day chores. So then there is no need to panic and maybe send them to hospital. So we see many patients in the community whose vital signs are not very normal, but they are stable. So if you are in the community or even on the ward, abnormal vital signs do not necessarily mean that the patient is not stable. So we have to look at other things to complete the picture, to come to a conclusion as to whether this patient is stable or not. And so some of the things we need to look at are, is the patient more confused than usual? Are they more sleepy? Are they walking less? They are not wanting to get up. Are they feeling low? Is there worsening incontinence, or is there new incontinence? Are they passing urine, or are they opening their bowels? Are they eating or drinking less? Have they had recent falls? So once you find some of these factors and then you combine them with the abnormal vital signs, then that can help you make a decision as to what you need to do. So yeah, so in the multi-complexity, another issue that is there is falls. I am sure you've heard a lot about falls. So a fall is an event which results in a person coming to rest inadvertently on the ground or floor or other lower level. So the prevalence is about 30% of over 65-year-olds and 50% of 80-year-olds. All these have at least, they have a fall at least once a year. These statistics are quite high, so that is 1 in 3 people and in the over 65-year-olds, and that's 1 in 2 in the 80-year-olds. That's a lot of people. So when we are going to assess falls, what do we do? There's what's called the multifactorial multifactorial falls risk assessment. So we have to look at the big picture, and we can't just look at the muscles or the balance. We have to look at everything. And this includes the cognitive function, continence, falls history, footwear, medication, balance, mobility problems, and I would normally, so if someone had a fall, these are some of the questions. So what happened? I would want them to tell me how the fall happened. So did they fall forwards? Did they fall backwards? Did they fall on the stairs? Did they trip? What happened? Did they pass out? They know what was happening. And then after finding out that, I would want to know, have they had other falls in the past 6 or 12 months? I have to know the details of those other falls as well. Are they happening in the same location? If they were falling maybe in the kitchen all the time, then we might want to check, is something in the kitchen? If they are falling in the bedroom or while they are getting out of bed, could it be the bed height that is the issue? So we want to know the details of the falls. So it's not enough to just record 2 falls, 20 falls. No, it's important that we get the other details. And also another key thing to think about is when they fall, when they fell, were they able to get up by themselves? And if not, what happened? Did they call the ambulance? How did they get to the phone? Some will say, oh, I crawled up to the phone. Or I bottom shuffled up to the phone, or I banged on the wall. So these are some of the stories we hear. I banged on the wall and then the neighbor heard me, and then they called the ambulance. So if someone lives on their own, we don't want them to continue to be at risk, because if they had a fall and they were not able to get to the phone, or they were not able to bang on the wall, then that would mean on the floor for a prolonged period of time. And we know if they stay on the floor for long, they're going to end up with hypothermia, and they are going to end up with probably with pressure sores, which obviously take long to heal because of the nature of frail older people. So we want to make sure they are not left in that vulnerable position. And I would normally say, so do you have a pendant alarm? So it's a little thing they can wear around their neck or around their wrist. And then if they had a fall, they can just press it, and then someone on the other end of the call will answer and say, Mrs. Jones, are you okay? And then they'll say, I'm on the floor. And then that person calls for the ambulance. There are other gadgets that people can have. So there are some gadgets, like someone can wear it and it can sense if someone has fallen. So changes in the angles, it goes off, and it can sense that the person has fallen, and then it goes off. And then there are other things, like if somebody was living with other people in the same house, and we are trying to minimize the risk of falls, and then this person, the people they live with, are able to supervise mobility. We can liaise with our OT colleagues or with social services, and they can install some equipment that senses if somebody has gotten up. So like a sensor mat, if they step on it, then whoever is in the building can tell that the person is now getting up, and they rush over and make sure that they supervise the mobility. So even the things we cannot do something about physically, we do make the appropriate referrals. And obviously, if someone said that they collapsed, they blacked out, then that could be because of a medical condition. It could be a heart problem. It could be a mini stroke. It could be something. So we want to alert the GP, and then they can do the appropriate investigations. So falls, again, nutrition is a big factor when it comes to falls in the frailer older people. So if they're not eating well, not going to have energy, and then they'll end up falling. So when I go in to see a patient, I ask them if they're eating well. So normally they'll say, oh, I've gone off my food, I don't have appetite. Yeah, so there's the malnutrition universal screening tool. So we have to complete it, and you ask the questions about eating, about drinking, how much, even when you ask about drinking, because there's what's recommended. So I would normally tell them what's recommended is about 6 to 8 glasses of water, and they'll tell you, oh, I drank 2 cups of tea. And I'm like, okay, that's good, but we need a bit more. And also there is the diuretic effect of tea. So they will drink, but then it kind of encourages the body to get rid of the water. So we need to encourage them to drink actual water. And then for those who say, oh, I don't like water, I meet very many of them. They say, I don't like water. And I'll say, okay, you can flavor it. So you can cut a piece of fruit and put it in the water. So a bit of lemon, a bit of cucumber, a bit of something to flavor it. Yeah. So that's hydration. And another thing with hydration, if they become dehydrated, obviously they are at risk of collapsing and falling, but also there's the risk of UTIs, urinary tract infections. So I do encourage patients to drink plenty so as to minimize the risk of UTIs, because UTIs are so then there's the issue of alcohol. If someone is drinking and they are falling, you will go in. I had one patient who was referred to us, and I went in, and there's nothing we could do. You can only advise them to stop, but even if you give all the balance exercises, they will still fall because of the alcohol. So if we go to exercise, so in terms of preventing falls or reducing the falls risk, so what's recommended for over 65-year-olds is 150 minutes a week of moderate intensity. I think that's for the general public. Yeah, for everybody, or 75 minutes a week, vigorous intensity, or a combination of both. So for older people, we want to make sure that they also do exercises that improve strength at least 2 days a week. And actually that's for all of us anyway. So when we see patients who are frail, what do we normally do? We normally give seated exercises. So you'll find someone who is not able to stand, they are not safe, so we will give seated exercises. And then when after the assessments and you find someone has, you generally personalize the care. So you prescribe exercises based on your findings. And most of the balance exercises we give are the Otago exercises, and they are different levels. So level 1 up to level 4. And one thing I wanted to draw our attention to is the principle. So when you're prescribing exercise, you want to think about the frequency, intensity, time, and type. So as we give advice about exercise, we need to bear those I have this video, I don't know if I can try. So I've clicked on it. It shows women who are doing strength training. It is whirling, so it will probably not play.
Justine, I can pop it in the chat just in case people want to look at it afterwards.
Yeah, sure.
There we go.
Another time. Okay. Yeah. So one things. So my background, I wear different hats. I trained as a as a gym instructor a few years ago, and I also have a master's in public health. So I am more into prevention. I'm passionate about prevention of things rather than waiting for people to be ill and then they come to us. So one of the challenges I see, one of the things I see as a challenge is the type of exercise we give. Sometimes we prescribe seated exercises. Okay, I'm not going to say we. Some therapists will prescribe seated exercises for everybody, and you find that actually, if someone is higher functioning, then they need a different set of exercises. So the principle of progression, we need to bear that in mind. And then in different places, so physiotherapists work in different places. So we are in the acute inpatient, in the rehab, community rehab wards, and also, so all those have different pathways. And those pathways have different durations. So like some inpatient rehab units, the patient can only be there for 2 weeks. Last year, I was working with the prevention of admissions in our trust. That's the admission avoidance, and the pathway is 1 week. And then you support the patient for 1 week, do everything very quickly. And then if they need more input, you refer to the next, to the community therapy team that has a pathway that's 6 weeks. And then that 6 week pathway is, the most they can do is like once a week. The most visits they can do is once a week. So I find that it works, but then you find some patients who are not able to do a lot when you're not there. So the adherence can be a bit of a problem. So that's something that personally I find a challenge. So it would be good if we had lots of onward referral services where, like, after you've given your intervention for 6 weeks or for 2 weeks or whatever it is, and then you can pass the people on. And again, when you discharge this patient, sometimes they're at the right point and they are okay to continue with the exercises you've given them. But then a couple of weeks later, they've maybe outgrown, in quotes, outgrown those exercises, and they could do with an advanced set of exercises. So that's why it would be great if we could have lots of onward referral services that we can refer some of these patients to. And then another thing I would like us to think about as physiotherapists is the reactive versus if it is important that we start doing more that leans towards prevention, towards the prevention model rather than the biomedical model. So biomedical model is where a patient becomes ill and then they come to you and then you treat them and then they go away. Michael Marmot, who talks a lot about health inequalities, says that you see the patient and then you send them back to the conditions that made them ill in the first place. So then they go, the dose you've given them keeps them going for a bit, then they become ill again, then they come back. So you end up with what we call a revolving door situation. So then the last M is what matters most. Matters most. And so we have to think about what is the patient's definition of frailty. So, or what's their definition of what the problem is. So when I go in to see a patient, I usually ask them, what do you think is your main problem? Because whoever has referred them, it could be an inpatient physio, it could be the GP, they have their own definition of what the problem is. So I normally ask my patient, what is your main problem? Because it's important to hear it in their own words. And so then that would help us think about person-centered approaches. So for us, we might say, okay, the problem is reduced mobility. For them, they might say, oh, my main problem is I'm not able to go to the shop and do my shopping, or I'm not able to walk across and see my neighbor who I used to visit regularly. So it's important that we hear it from them, and then we set the goals based on what they think is the main issue. Then interaction with the patients. We need to introduce ourselves. So there was this campaign called My Name Is. So it's important that we always say who we are, where we're coming from. Hi, I'm Justine. I work with I'm a physiotherapist with the prevention of admissions team. And then I can explain. So communication is key for frail patients. So especially those who have issues to do with the mind, so dementia, delirium, it's very important that we explain what's going on, we explain why we are there, we explain what we are trying to do. Like I said earlier, if you're going to touch them, tell them, I'm going to touch you on your arm, or I'm going to touch here on the leg, just so they know what you're doing and why. Otherwise, if they don't know, and it can aggravate their condition, and they could become aggressive. So then we have to think about choice and dignity. So sometimes some patients will actually say they do not want the treatment, or so if they say they do not want the treatment, you can choose to offer a different option of the treatment, or you might not be able to push, and that is their choice. So we have to bear that in mind. But for me, I would normally try and offer a different way, just to make sure all bases are covered. And also I aim to explain the risk of them not doing what we are suggesting. So it's important that you explain things to them, because if you explain the risk, then they might change their mind. So that choice and dignity we need to give to them, whether they are whether they are confused or not. And then we need to listen to them, listen to their wishes, listen to their worries. And I find that physiotherapists, we are very privileged. We have a door with these patients. There is a way that we build rapport with them. As you practice that walk, they are walking slowly, or that sit to stand, they sit, they stand, then they sit, and you give them a bit of a break before the next stand. They are talking, they are talking to you about things. So it's important that we listen, and then pick out what we need to act on, and see what we can do to support our patients better. And some of the things might not be physio related at all. It could be that they're worried about their son who lives abroad. We had a patient whose son was abroad, and we facilitated for them to have a conversation. So it's little things like that. So you do that, and it brightens the patient up, and it improves their morale, and they're able to engage with your exercise program better. But if you just go in and your mind is just on the exercise and the movement and the mobility practice, it might be that if they have other things on their mind, they might not engage as well. So then care planning, obviously that's goal setting, which I'm sure you know about. So that's very important. And then finally, there's advanced care planning. So that is about for end stage frailty. So for people who in their last couple of months of being alive, we need to have conversations with them about their last few days, like how they want to die, where they want to die. So that's part of the holistic care we are called to provide. Obviously, that is new for a lot of people. It can be new. Usually it's nurses and doctors who have these conversations. But like you saw earlier on, the comprehensive geriatric assessment and the multifactorial falls risk assessment and intervention, it is very holistic. So we find ourselves doing many things. So these people's wishes, it's important that they get documented in advance. So if someone has a DNAR, CPR, it needs to be documented. And also if they've said they would like to die in their own home, it needs to be documented in that if there's a crisis and the paramedics come, then they don't take them to hospital. Because sometimes the doctors already know that this person has like 6 months to live. So in some instances, there is no need to take them into hospital. Yeah, in case of a crisis, they can be managed in their own environment. So it's important that we document these things in advance. So those of you who've not yet had any conversations like this one, at some point, if you're in the community, you might find yourself having to have them. Then the benefit of these conversations is it reduces the stress and anxiety for the relatives, because at the end of the day, when this patient passes away, then the relatives are left with the task to make the decisions about whether this patient wants to be buried or cremated, or what they wanted to do with their property. So it is very important that these conversations happen. And also it gives the patient like a bit of calm and peace, because like they've already organized things, and so they are more calm. And then if a patient has no capacity, we can ask the relatives about their previously expressed wishes. So that's how we deal with the advanced care planning. Obviously, there's more information about that, but so for now, this is all I could fit in. And thank you very much for listening. Frailty is a very broad subject, and I tried to compress it, which I don't know if I've done well, but yeah, it is very broad. So if you have any questions, I will take them. Thank you.
Thank you so much, Justine. That was absolutely fascinating. It was so good to hear. Thank you very much. I'm going to pass over to Leesha now. If anyone would like to pop any questions into the Q&A for Justine, she can be starting to look at those, and then we will have a bit of time after Leesha's spoken to pick up any other Q&As. Leesha, over to you.
Thank you. Justine, I also just want to say thank you so much for such a great presentation. Frailty is such an important topic for us to know and learn about, and there's so many of those principles that can be applied to wider patient groups as well. So thank you for teaching us about it all. I'm sure a lot of us have taken so much away from it, because I know that I definitely have. And I just want to say thanks to Sarah as well. I'm sure a lot of you have noticed in the chat that she's very kindly shared some additional information throughout the presentation. Sarah is Agile's chair, so thank you, Sarah. I'm just going to go ahead and share my screen now, as we're going to talk about Agile and Agile student membership. So I'll just share my screen, and then I'll hand back over to Justine for a short while longer just to talk about what Agile is and what their aims are. So over to you, Justine.
Lovely. Thank you very much.
Thank you.
Agile. So Agile is it's a professional network recognized by the CSP for physiotherapists who work with older people. I love Agile. I am the East of England regional representative. Yeah, so it's been a great journey. I started doing that last year. So it is for qualified physiotherapists, it's for physiotherapy students, it's for therapy assistants, and we can have other members from other professions. So they can join us as associate members. So that's what Agile is, and our aim is to support members to deliver the highest possible physiotherapy practice to older people. So we sort out training and development resources, and obviously the key thing is evidence-based practice, and yeah, and then there's representing physiotherapists working with older people at regional and national forums to ensure policy and practice. We also consider, so we work with the national bodies. So like NICE, sometimes they do get in touch with us and ask us to comment on some of the policies they're trying to come up with, like the Parkinson's Society. So different organizations, different forums. So we engage with them, and then yeah, we input into that. So it is much fun. Next.
It won't let me move the slide along.
It's all right.
I can't find the button.
Yeah, so we do provide training. Like last year, we provided, we organized training for osteoporosis, and we worked with Later Life, and they brought us training around osteoporosis and rehabilitation for people with osteoporosis. It's all evidence-based practice. So we were sold out. We ran 3 of them, at 3 different intervals, the same training, and it was all sold out. So it's great training that we organize. So our aims to promote high standards of physiotherapy practice within older people, to develop and communicate policies to enable and support members to deliver clinically effective and value for money physiotherapy practice with older people based on research and education. And then to provide a supportive environment for members by facilitating the exchange of ideas and information, to encourage, support, and coordinate relevant activities regionally and nationally. And yeah, so those are some of the things we do. Yeah, the last one is to provide a representative body of physiotherapists. Sorry, someone had sent a question and it had blocked it. Yeah, so that's what we do as Agile, and it is a great body to belong to. We produce a what's it called? Agility.
Agility.
Yeah, so Agility it's like a journal. Oh yeah, it is here.
Yeah.
Thanks, Leesha. Yeah, so yeah, do you want to talk about that bit?
Yeah, sure. So by joining Agile, you'll have access to all of these fantastic benefits. So you'll receive an in-print version of Agile's Agility Journal twice a year. You'll be able to gain access to all Agile relevant resources via the Agile website, and regional communications as well, such as recent publications and exercise and outcome measure manuals, which can be really helpful for while you're on placement in an area that might use them. You'll also be able to receive discount on any Agile Run courses, the Agile Conference, and later life training courses as well. And after 2 years of consecutive membership, you'll be able to apply to the National Agile Committee for funding for courses, research, and quality improvement too. How much does it cost to join Agile as a student member? Only £5 a year. So that's often considered reasonably affordable, and it's great value for money as you get all of those benefits for only £5. So you can choose to pay £5 yearly and renew it each year, or you can choose to pay for the duration of your course up front. So for example, a 3-year course would be £15. If you wanted to pay it all in one go, then you're covered for the duration of your studies at uni, and equally a 4-year course for £20 for the 4 years. So how can you join Agile as a student member? So if you are a physio student and you'd like to join Agile as a student member and gain access to all of these great benefits, then you can email the email address on this slide. So it's agile.membership@gmail.com, and they'll be able to guide you further on how you can make your student membership payment. So that's the Agile's membership secretary that you'll be in contact with there. And any non-CSP student member applications. So if you're not a member of the CSP already, which I'm sure the majority of you here will be since you're on this webinar, but if there are any non-CSP student members that are applying, they'll be accepted and considered by a case-by-case basis. So where can you find out more about Agile or contact us? The website address is just here on this slide. And on Twitter, it's @AgileCSP, and you can email either of the 2 email addresses there at the bottom for any further information. So the membership secretary address again, and then that's my student officer email address if you'd like to get in touch for any more information about student membership or what Agile does. And then lastly, just before we move on to a quick Q&A, we'd just like to know what you've taken away from this webinar. So if you go on to www.ment.com on your laptop or a phone, whichever you've got near you, and just type in that code at the bottom, a question should pop up that asks, what have you taken away from this webinar? And I'll share that screen in a second so we can see the live responses coming in, hopefully. Yeah, we'd be really keen to hear the key points that you've taken away from this webinar. And we really appreciate you all joining us tonight. So thank you, and please pop any questions in the chat.
Thank you, Leesha, that's fantastic. So whilst people are completing the poll on menti.com, I just wanted to pick up on a question I've seen in the Q&A. Justine, can you see that question that's come in asking about support for patients with dementia?
Yes.
Can you see that okay? Because if not, I can read it out.
Yeah, I can see it. So yeah, you want to read it out?
Yeah, sure. Okay. So firstly, thank you for the presentation. It was super helpful. So thank you for that comment. So this person has a question relating to patients with dementia. What sort of strategies do you find are most beneficial for helping them remember an exercise routine or general medical routines, for example, their medication, etc.? I'm aware of basic ideas such as posters or post-it note routines for them at home, but are there any helpful inpatient techniques that might help if you're unable to see them daily?
Okay, thanks for that question. So you've got some good tips there already. So some of the things are like reminders. Obviously, we have to think about the practicality and whether those are things that our departments are willing to purchase, but reminders can be helpful. So for like for their medication, some of them have, there are some gadgets that you can set the time and then it rings when it's time for their medication, and then they take their medication and then they switch it off. So I have met some of them in the community with those reminders, especially for like Parkinson's patients who have to take their medication bang on time. Yeah, so that works even for dementia patients. Obviously, it depends on the extent of the dementia, whether it's mild or moderate. So mild to moderate, then the reminder can work. Yeah, so the post-it notes, they are great. And maybe family members, we can utilize family members. That's sorry, when I think mainly in community setting, because I've been in the community for so long. But in terms of hospital, inpatient, it could be that we pop in and remind them, or encourage the support staff, support staff and the nurses. So if we put like an exercise diary or timetable, timetable, and then if we put it up, and then after they've done, they can tick. So then we can encourage, we can involve the nurses and the support staff in that. And also, obviously, when family members start visiting, now that things are opening up, then they can also be part of it. Yeah, so that's how we can do it. But in terms of, but also in terms of keeping the patients active, it doesn't have to stop at the exercises, like the exercises we prescribe. So if we support the nurses and the support staff to engage the patient in activity, in the general activity, so like sitting on the edge of the bed for someone whose balance is appropriate but not as good, whose sitting balance is not as good. So if they are able to sit up safely just for their meals, then that can work as a rehab session, if that makes sense. And then rather than them being sat on the wheelchair or the commode and wheeled to the toilet, they could try and mobilize them to the toilet. So it could be that when we make it a bit more functional, it could make more impact. So for people with dementia, sometimes you might be trying to explain things and some of them they are not understanding. But if you say, let's walk, then that is an easy thing for them to understand, or stand up and sit down, rather than saying bend your knee or something like that. So there's nothing wrong with that, but that is good. But we can also focus a bit more on the functional side of things. Thank you.
Thank you so much, Justine. Any other comments on what do you find the main challenges to be, students out there listening, with regards to frailty learning and development? What could Agile do that may help you reach any learning needs you can have, that you may have? So if you'd like to send an email, I'm just conscious of time. If you want to email instead, do get in touch with our panelists. So you can email various ways. We've got the studentofficer.agile@gmail.com, or the main Agile inquiry mailbox, which is agile.membership. So that's your membership one at gmail.com. Okay, as I say there, I am conscious of time. So I would just like to run a final poll. It's really short, I promise. Just an evaluation poll. We'd really appreciate your feedback tonight. And you can always email us at studentinquiries@csp.org.uk. I should just pop that up there. If you've got any questions at all, or if you've got any suggestions for other webinars that you might like, that would be useful, we're always here to, to hear your feedback and your ideas as well, obviously. So whilst you're just completing that, I want to say a huge thank you to Justine for your contribution this evening. It's been really, really interesting. Thank you very much indeed. It was a fantastic presentation. Thank you to Leesha as well, of course. Student rep of everything. So you've been amazing. Thank you very much. And And thank you all for joining as well. I know it's just such a busy time for you, so I really appreciate the time that you've all taken. I'm sure you've got a lot out of the session. Just to confirm, we will be sending the recording. I'll also send some of the notes that were coming through from Sarah in the chat. So I think they'll make sense when you go through the slides, because I will send the slides across to you as well. Okay, so thank you very much. Take care of yourselves, everybody. Enjoy the rest of your evening.
Thank you, everyone, for being here.
Thank you.
Thanks, everybody. Bye for now.
Thank you. Bye-bye.
Bye.